And if I go, okay, so that's something that you could see afterwards, especially for my Hungarian-speaking colleagues. So without further ado, I think I put a fair amount of information in this. So I'm going to talk about neuroimaging and reviews. Part of this advocacy, part of this is political, and obviously educational. So, in America, we have to say who we do research with and who do we get any financial support of. All these companies here are really only supporting my research in other fields of medicine, mostly headache, but also brain tumors, but nothing really neuroimaging related. So I really have nothing to disclose. Many of you know that the Neurological Institute here, and I see my good colleague and friend, Dr. Fritz, who's now the president of the American Society of Neuroimaging. We're very proud of him. And we've built a neuroscience center that is in Buffalo, Williams, and Orchard Park. We have about 85 providers, 20 clinical subspecialties or centers of excellence, 15 ancillary service sites. We see about 305,000 patients a year, which is about 1,250 a day in the neurosciences. But we do about 130 MRIs a day, which is very important. Presently we had 6 machines, now we have 5. And we all know that in Budapest we have the Mind Institute, which is beautiful, and at Roswell Park is where I do my brain tumor neuro-oncology most of the time. I've been there since 1991. So I want to put this up because the strength of the leader, if your actions inspire others to dream more, learn more, do more, become more, you are a leader. That's why I enjoy teaching young students, residents, fellows, because you can change their path in medicine. I have a young lady here from England who wanted to be everything but a neurologist. Well, now she's reconsidering becoming a neurologist. And that's what we do. We give people opportunity to go into a pathway, something that was influenced by your teaching. And I firmly believe that's very important in everything we do. The Dent success, the Institute's success, it's an academic, large private practice. We have these centers of excellence. We have wonderful ancillary support, including infusion lab, imaging, electromyography, sleep. I can go down the list. It's multidisciplinary, geographic diversified, strength is in numbers, meaning we have a lot of people here, over 500 people working at the Dent, strong networking relationships. So this is part of the success, and this is an award we recently received for Business of the Year in Western New York. So what do we do? Well, we have a lot of things we do. We have centers for dementia, vertigo, a headache center that is quite large, MS, movement disorder, pediatric, psychs, oncology, seizure, stroke. So we basically, the last one, brain gut center, really came from the influence of Dr. Richard Schwab, who really taught me a lot about the relationship between the GI tract, the microbiome, and neurological disorders such as Alzheimer's, Parkinson's, migraines. So I thank him for that, because now I started a brain gut center at the Dent with the support of Dr. Fritz, who strongly feels that this is very important in our institute. So that's the newest thing, just started this July at the Dent. When it comes to ancillaries, you can see we have all MRI, ultrasonography, CT, PET is off campus, a very, very robust infusion center, a lot of chemodenervation, trigger points, nerve blocks, EEG, EMG, sleep, transmagnetic stimulation, pain intervention, ketamine clinic, and something that I developed a few years ago, which is a cannabis clinic where we have over 13,000 patients. So the highlight is that we have subspecialty expertise, high volume, comprehensive protocol control, and integrated feedback. This is a little background on our success. So I threw this for my Hungarian colleagues because I think it's possible for ordinary people to choose to be extraordinary. Elon Musk comes from South Africa, who has, but what I did was I was born in Australia, but I come from a family of auto mechanics, and I was a young auto mechanic from age 15 to 23. And that's what I did. I worked on cars. I still have patients come to me in Buffalo who say, I remember you work in my car. And for my Hungarian friends, my father and my mother there who have passed were so Hungarian centric that the building, the garage that we built was colored red, white, and green. And for people who may not know what red, white, and green means, that's the Hungarian flag. It's not the Italian flag because that would be vertical. So this is what we mean that you don't have to have the highest education to change things in the field of neurology or neuroimaging. In neuroimaging, I've been the past president of the American Society of Neuroimaging, which is what Dr. Fritz is presently, and I've been on the editor for neuroimaging and continuum. And so my research has been emphasized in neuroimaging. And one of the reasons I thought neuroimaging was important is because neurologists in the United States, and again, we have a lot of people from the United States here, neurologists in general have a difficult time finding their place in the field of medicine for many reasons. One is there's a shortage of neurologists, especially in the rural areas. The shortage is real, and as neurological disorders become more common, for example, Alzheimer's, as our age population is older, we're going to see more and more neurological disorders with less and less neurologists. And the neurology burnout, which is a real number, is about 51%, which means that neurologists in general are unhappy. They feel burnt out. They feel that their reimbursement is not adequate. So my goal for many years has been to see if I could influence neurological care in the United States and improve the quality of life of neurologists. Hence, I was very strong in imaging. So we have to remember that neurologists, are very well trained, very knowledgeable, but not well respected in the community, not in the patient community, but in the world of hospital systems, academics. Neurologists tend to be felt to be very academic and not influential like neurosurgeons or cardiothoracic surgeons. So one of the reasons I have had a good fight with the American Academy of Neurology to have them recognize that neuroimaging should be under the dome, under the supervision of neurologists who are trained in neuroimaging. Not just neurologists, you need extra training. And we have residents in the audience. I don't think that the training for neurologists in neuroimaging is adequate. But I will emphasize, as American Academy of Neurology grasps with the concept that neurology should not be neuroimaging, or we lost neuroimaging many years ago to the radiologists. In cardiovascular imaging, there's over 35 institutions offering advanced cardiovascular imaging fellowships for cardiologists in the United States at places such as UCSF, Johns Hopkins, in Texas, in Houston. So all over the country, major academic centers are teaching cardiologists to image the heart. Well, if that's true, we should be having multiple centers in the United States teaching neurologists to image the brain. What I did this year, which is very unique, I took a Hungarian-trained young doctor, offered her a fellowship in neuroimaging before she does neurology. That's rather unique, but that's very forward-thinking, and her expertise in neuroimaging will guide her in her neurology residency program. So organ-specific imaging, I don't see why a heart is more difficult than the brain. And often it feels like in imaging for neurologists, it's us against them. Well, you know what? It really isn't, because neuroradiologists accept a well-trained neurologist in imaging. It's really us against them, meaning the general radiologists. So in regard to imaging and the reality of neurology, you can't evade reality, but we can evade reality, but we cannot evade the consequences of evading reality. So we have to remember that neurologists are dependent on imaging to make decisions. And many neurologists make decisions by themselves. For example, the stroke specialist in the hospital, they read an MRI, they make a decision, and next day there's a radiological reading. So we have to take over some of the imaging. So that was the advocacy and somewhat political part of my discussion. Now I want to kind of walk you through the types of imaging. Yes, there's CT, which we call anatomic or structural imaging, CT, MRI, and ultrasound, but there's something called functional imaging, PET, SPEC, functional MRS, DTI, and a few other modalities. So my talk is going to start off with CT. So at the Dent Neurologic Institute, I had the honor and the pleasure to be trained by a wonderful visionary, Dr. William Kinkle, who started at Dent in 1963. He just passed away last year at age 93. And he was a visionary. A visionary meaning he, in early 1970s, saw a lecture in New York City with the first images of a CT scan that was made by Sir Geoffrey Hounsfield, and that was in England. And many of you may not know what English company developed the first CT scanner with Hounsfield, and it may surprise you, it's not Siemens or GE or Philips, but it was a company called EMI. And if you're not sure what EMI was actually the Beatles. EMI Records developed all the Beatles music, and then some of the money went to development of CT, which changed the course of medicine as we know it. So that's the history. Geoffrey Hounsfield, electromusical instruments. If you ever want to talk about the development of CT, was really on the backs of the success of the Beatles. So what are the advantages of CAT scan? I will say that the majority of what neurologists order today are actually MRI, but we still have a opportunity to order CT scans, especially in hospitals where CT is 24/7, emergency rooms have it, but there are some advantages and disadvantages. The advantages, it's quite fast, it's convenient, it's readily available. Is it cost effective? Well, that's changing in the United States, where MRIs were thousands of dollars and 60 minutes long. Now we've got down to 8-minute, 10-minute MRIs for $280 and so on. So, and CT is slightly cheaper, but the delta difference between CT and MRI is not there anymore. More suitable for patients unable to cooperate, true. Better for acute head trauma and subarachnoid hemorrhage, true. And here's a CT scan that you can see the hyperdensity within the inner hemispheric fissure, the sylvian fissure. This is obviously a subarachnoid hemorrhage. Disadvantages, radiation. Now, 2% of cancers in the United States, 2%, are related to overuse of CT scan, especially in children developing leukemias. Risk of severe allergic reaction is true with iodine contrast material. Now, limited to the axial and transverse plane. Now, the faster CT scans, and we had a 320 slice CT scanner at the Dent, are very fast, and you can get in multiple planes. So we know that CT is less sensitive in the cerebellum or posterior fossa. So here's a case, and I put this up because this is obviously a young child, and in the audience, I'm going to ask real fast. I'm not going to wait too long. What is the cause of this injury? Does anybody know? You can chime in if you want. Here's a CT scan with bone pieces. You see it intracranially over here. I presume you see my arrow on the left. Is it seen there? Yeah. You see here the bone window. And then here is a 3D reconstruction. 1, 2. Well, this is, I don't see anybody answering, but this is a dog bite. Oh, somebody will answer just a tad late, but this is a dog bite. And CT gives you the luxury to look at fractures, fracture lines, injury to the skull. So there is an advantage to CT in some patients, especially with acute trauma. Now, I'm going to go beyond CT because I'll be honest with you. We've been looking at our numbers. For every 500 MRIs we order 1 CT in an outpatient setting. I know that's different in an inpatient setting. We have to respect that. But MRI is far more sensitive for the parenchyma, for the smaller structures in the brain than a CT scan. And MRI gives you advantage that it's non-radiation, very reproducible, safe. And when we look at MRI, we look at these sequences: DWI, T1, T2, flare, grade echo, SWI, ADC, and there's more sequences which I'll get into. So we look at the sequences. MRI is also very important because when you order a CT, you order a CT, but when you order MRI, you have to tell the tech, the radiologist, what are you looking for? What sequences do you really want? Now, MRI has the unfortunate distinction that there have been 1 or 2 patients who actually died from an MRI because the magnet was turned on, it sucked in an oxygen tank, unfortunately it hit the child in the head who passed away. This is somebody whose ICU bed was not compatible with MRI, as you can see. So MRI is large magnets, and those large magnets have contraindications. The contraindications is aneurysm clips. Now, in the United States, I have to tell you, over the last 15 years, I've not seen an aneurysm clip that is not MRI compatible. But so anything before 85, 86, you have to ask the question, is the aneurysm clip compatible with MRI? Intraocular foreign bodies in people like welders, people who work with metal, you have to do a pre-MRI X-ray. Subcutaneous metal shards, implanted neurostimulators, pacemakers. Well, pacemakers have changed because now in America, you have an option. You can get a pacemaker that is MRI compatible, or you can get a pacemaker that's not MRI compatible. One's a little bit more expensive than the other, but I recommend that anybody getting a pacemaker should be an MRI compatible pacemaker. In fact, we did the early work on pacemaker MRIs at the Dent several years ago. Prosthetic heart valves, cochlear implants is an issue. So I use this in America to teach residents and fellows and young neurologists who are told that the MRI costs about $2,000 to $3,000. But in fact, it really costs about $280 non-contract. So $280 in America is a battery of blood tests. So the concept that MRI is just too expensive and you need to stay away from it is not true anymore. These were the prices in Texas, and the MRI study for fully insured was anywhere from $375 to $10,000. Imagine there were some MRIs for $42,000, which is rare but can occur because MRIs are more expensive in hospitals than they are in freestanding outpatient centers. I wish Hungary would understand that because the cost of an MRI in an outpatient setting, like at the Mind, should be far less and more cost effective. The problem with MRI in the United States, I mean, the United States being the center of capitalism in the world, is that the insurance companies, the payers, will pay for an MRI even if you have a Bentley or you have a Fiat 800. What that means is they don't care about the quality of the machinery, which unfortunately, people are starting to buy cheap MRIs, cost-effective MRIs. Here at the Dent and at the Mind, we went out and bought the best MRIs in the world, but the reimbursement from the insurance company doesn't change, which is unfortunate. But nowhere in business do you rent a car from Avis or Hertz at the same price for different quality cars. You always have a discrepancy in rentals. And the other problem is outpatient and in hospital is that outpatient MRI is far less expensive. Like I said, at the Dent, we talk about $300. In a hospital, it could be anywhere from $1,500 to $3,000. At MD Anderson in Houston, where I trained, and my lecture was actually in Austin, Texas, the MRI, I called them up. I said, look, I don't have any, I'm a self-pay. I want to pay for the MRI. How much does it cost me? For a head MRI, with and without contrast was $7,578. And again, in an outpatient setting, it's about $280. So that's a little bit about the medical economics of MRI. But let me talk to you. The one problem is that individuals who are not comfortable with MRI of the brain don't know that there are such things as normal variants. And often when you have an official reading, the radiologist who does not have the clinical expertise to understand what a normal variance in the brain will emphasize these abnormalities. And I'm going to go through a few of them. So this is Edward Munch's Norwegian, the scream. So I'm saying, be happy, don't worry when you see these things. For example, here in front of you, you have 6 different MRIs. Here's a flare, and this is a classic location of a choroidal fissure cyst, which is a benign entity, nothing to worry about. Another benign entity, nothing to worry about. A choroidal plexus cyst, which on DWI can show restrictive diffusion, but is especially when they're symmetric, is an incidental finding, nothing to worry about. These MRIs are published in an article I wrote about imaging and headaches. Don't worry about these problems. This is a developmental venous anomaly. Although it looks like it could be an AVM, this is intravascular enhancement without flare changes. So this is a DVA. We used to call that venous angioma. Do not operate on these cases, because if you do, you will cause a venous infarct. The D is a Thornwell cyst, which is in the nasopharynx. The only thing that's associated is bad breath, halitosis. The E is ependymitis granularis, which is a normal variant frontal horn capping. It is not microangiopathy, and it's not MS. And then the last one are these radial perivascular spaces that you see here. That's a normal variant. You can see it in the basal ganglia. You can see it in the midbrain, and you see it in the subcortical white matter. It's a normal variant. Here's a case of a patient that was sent to me with bad headaches. And this also was sent to a neurosurgeon. And they thought these were big cysts. The patient had headaches. But if you look close enough, you'll see that, okay, there's bilateral, relatively symmetric arachnoid cyst. You can see the flare and the T2 weighted changes in the adenoid sinus. We treated the sinusitis. As you can see, it's cleared up. The arachnoid cysts are still there, and the headaches went away. So here's a patient, and I see this all the time. I saw it yesterday. A patient had an abnormality in their brain. They immediately said, we see something in the brain. The patient has headaches. We need to take care of this. That's not the case. You treat the headache, and then afterwards look at the incidental finding. In this case, it was bilateral arachnoid cysts. So let me talk about brain tumors, which is part of what I do here in Buffalo. In brain tumors, headaches occur in about 50% of patients, more often in pediatrics. And the reason pediatrics headaches are more headaches in kids are more common, because 2/3 of tumors in children are posterior fossa in location. 2/3 in adults is supratentorial. So that's why headaches are more common in kids. The classic triad: poor sleep, severe pain, nausea, vomiting, really doesn't occur that often, because we're picking up tumors much earlier. Focal neurological deficits, seizures, these are just some. So here's a patient. The first question you ask when you see a mass in the brain, the first question, is this intra or is this extraaxial? Intraaxial means, is it in the parenchyma or is it outside the parenchyma? And here, as you can see on a non-contrast patient who had headaches and dementia, you see this large mass that's extraaxial, outside the brain. You see the CSF cleft. This is a homogeneous enhancement. Obviously, this turned out to be a meningioma, resected, headaches went away, and cognition. So my approach to a brain tumor, if it's intraaxial versus extraaxial, look at the location. Is it supra or infratentorial? Look at the age. Is this pediatric? Is this adult? And look at the imaging characteristics. It's very important that you look at this, the type of signal originating from the abnormality. Could this be something other than a neoplasm? That's always interesting. The problem with MRI is that if you look at the sequences, the intensity, pathology with MRI is bright on flare / T2 and dark on T1. 80% of pathology, you think about it, is always bright on T2 and dark on T1. So this intensity of the lesion may not always help you. Then it becomes location. Here's a patient with a mesial temporal T1 hypointensity. Here's a flare abnormality, extends to the cortex to involve the cortex. So this turned out to be an oligodendroglioma, which preferentially extends to the gray matter. And so, but the reason I knew this was an oligo is because of its topography and its location. But here's a case where it's actually an interesting case of a patient of mine who presented with acute headaches. You see early obstructive hydrocephalus, the 21-year-old, and you see these T1 speckles of hyperintensities. We call that an area of short T1. Now, I did a fat suppression study, and it turns out that this was a ruptured dermoid with obstructive hydrocephalus. So a STIR sequence, which is short tau inversion recovery, or a fat suppression study, gives you help when you look at these abnormalities. And this is the case, actually, this pathology was intraoperative images. You see the dermoid, which is that yellow. It's very pernicious, and hence you'll see an area short T1, which is bright on T1. So the reason I mentioned that case, that dermoid case, is that if you know that what's bright on T2 is pathology and what's dark on T1 is pathology, let's change the rules. What is dark on T2? What is bright on T1? And if you know this map here, you know that what's dark on T2 is, for example, air, sinuses, hemosiderin, chronic or desoxyhemoglobin, melanin ferritin calcification. What's interesting is that T2 becomes hyperintense in hypercellular tumor. The reason that happens is you get a lot of cell membrane DNR, RNA in tumors such as lymphomas, medulloblastomas, germinomas. So that gives you T2 hyperintensity. T1, then let's move on over and go back to T2. Colon carcinoma has mucin, so it's dark on T2. Craniopharyngiomas, colloid cysts, hemangioblastomas because of fast-flowing blood. So what's bright on T1? Melanin, manganese, calcium, high protein, colloid cyst, methemoglobin, fat. Fat's big on here. So if you can memorize this, and again, this lecture is going to be taped and be on the Mind website, I would recommend that you learn this graph here, because that will give you enough information to help you with your differential diagnosis. This is a patient, 35 years old, woman, comes to me and has a bad headache, and we found this mass. You see there's midline shift, there's compression of the ventricular system, and on a non-contrast, let me emphasize, this is non-contrast, you have this bright signal and you have this fluid level in a capsule. When you give contrast, there's a little enhancement, not much. So when I look at this and I go back and say, well, what is bright on T1? I look at fat, I look at blood, I look at high protein. So this actually was a 35-year-old who had no past medical history, who had a resection. It turned out to be a melanoma. 5 years before that, she had a skin lesion taken off. She was a redhead with freckles, and she had a skin melanoma that was diagnosed as benign 5 years prior to her presentation. So that was a brain metastases melanoma. But it's the signal characteristics when I knew that this was a bloody metastases because it was bright on T1. Here's another issue. This is an individual. Now, if I show it to you, and it's T1 non-contrast, look at the fat in the orbits. It's bright fat in the scalp, and this is a bright T1. So what is this? So it could be a lipoma. Could this be a subarachnoid hemorrhage? Well, it doesn't look like one. So what I did a fat suppression. I did a fat-sat suppression sequence to suppress the signal. If it was blood, it would have remained bright. If it was fat, it suppresses it. So use all this for helping you differentiate and your differential diagnosis when it comes to abnormalities. So when do you use gadolinium with headache? Well, this is part of my chapter. I just updated it this year. Patients with abdominal neurologic examination, positional headaches, Valsalva, cluster. If you have a patient with cancer, AIDS, neurocutaneous disorders, or infectious disease, and the patient has a nuance of headache, please do image that person. So here I'm going about imaging in patients with headaches. The reason this patient has pachymeningeal engorgement, you see the tentorium cerebelli, which I'm showing you here, is very thick. You can see the meninges is very thick, interhemispheric fissure. The reason this is because the patient had a shunt placed and is overcompensated and has low intracranial pressure. So that's why you have to give contrast for patients with positional headaches, headaches worse by cough, sneeze. Now, this is a sequence that I really do enjoy ordering, and it's called susceptibly weighted image. It's a sequence that is about 6 to 8 times more sensitive than gradient echo or T2 star. And SWIs are ordered on a 3T and a 1.5. So here's a T2 weighted axial. You don't see too much, but when you do the SWI, you see these post-traumatic microhemorrhages here, here. And it's important that we routinely use SWI because here's a person, a 1.5, 3T. In cases like this, a 1.5 is going to be great. But you see this post-traumatic microhemorrhages. This, in fact, could have also been familiar cavernous malformation syndrome. These are hypointensities and SWI. SWI hyperintensity is either blood products, either dystrophic calcification, or it's flowing blood. This is a very interesting case that came to us. He was going to the emergency room for about 4 years because of back pain, and never had an imaging study because he used emergency room as his primary treatment plan. So he was working in Mississippi, Georgia, Alabama, then came up to Buffalo. And this is what the MRI, and he had a headache. And when he had the headache, it was one of the worst headaches of his life. And this is the MRI. This is SWI, this is T2. On SWI, you see what we call siderosis. You see this hypointensity in the sulci supra and infratentorially. And on T2, you actually can see the hemosiderin within the sulci. So what do? Well, obviously, we did an MR angiogram and a digital subtraction angiogram. It was negative. So then we call this cryptogenic subarachnoid hemorrhage. But remember, the patient went around for 4 years with back pain, never had an imaging study. So we did one. And this imaging study showed this mass here. Now, if you've never seen this, this is a classic imaging study of a myxopapillary ependymoma. And myxopapillary ependymomas can cause cryptogenic subarachnoid hemorrhage. You can see in the tumor, there's blood degradation products on this T2 weighted sequence. So this is a very interesting case that, in fact, my English student would love to publish, which would be a subarachnoid hemorrhage secondary to myxopapillary ependymoma with the imaging. And he's doing very well with headaches and so on. So dementia is a very hot topic now in America because we have 2 or 3 drugs in the pipeline for the treatment of dementia. So imaging is going to be of utmost importance because the diagnosis of these patients will be dependent on either the spinal tap or the imaging study. And in this case, they're using amyloid PET for evaluation of dementias. So we'll have to wait and find out exactly what the criteria will be when we can order these very expensive new medications for the treatment of Alzheimer's disease. But we know that Alzheimer's disease and other dementias are increasing in frequency. Unfortunately, I just recently found out that Bruce Willis, the actor, has frontal temporal dementia and is progressing quite fast. So there's vascular dementias, which is very important in smokers and hypertensives and diabetics. And then treatable illnesses, B12 deficiency, one of the most common, and alcohol, which is also very common. So we do use volumetric studies. Volumetric studies are important, not for the diagnosis, but more for the response to treatment and the progression over time. I know Dr. Schuchart's in the audience, and he's a neuropsychologist who specializes in this disorder, in dementias. So we do use volumetrics. Again, not for the specific diagnosis, because we use anatomic imaging also, but for following several cases, we see in this case, the hippocampa is in the first normative percentile. In this second patient, it is in the 46th northern percentile. So this is the Alzheimer's antibody imaging criteria, FDA approved. These are the new drugs coming out. And again, this is going to be, these drugs are very expensive. So we have to confirm the diagnosis either by amyloid PET or lumbar puncture, looking at elevated phosphorylated tau or reduced beta amyloid or low AB42 or AB40. So getting back to headaches, when do you order an MRI and headaches? These are the red flags. So when you order imaging is, and then we have a large headache center, it's the worst headache, subacute, chronic daily headaches. This is a list. I'm not going to go through this, but please do review this. And this helps you guide when you can order an imaging. Here's a patient who came to us, and his main complaint was that he was having difficulties putting his Buffalo Bills cap on. As you can see, two things here. There's a big bump, and there's an engorged arterial vessel right here. And when you look at the MRI, this is why you had difficulty putting a hat on. This is a post-op MRI, excellent resection, turned out to be a meningioma. So that was the start. So the problem with imaging is the transition of anatomy, physiology, and biology. MRI gives you anatomy and pathology, but doesn't give you the biology of the tumor. And so we have to turn to advanced neuroimaging, diffusion-weighted imaging, functional MRI, perfusion. I go through these lists and give you some examples. Here's a patient with a diffuse tensor imaging in an AVM who had functional superimposed MRI prior to surgery. And we often will combine. The problem with MRI, what we've done today, we have 5 different disorders in front of you. And I would ask you, if I had more time, to what is what? Which one's the glioblastoma out of all of these? That's the first one. That's a glioblastoma, necrotic mass. That's an abscess, DWI positive. That's tuberculoma. The most common tumor in India is tuberculomas. And this is, over here is demyelinating disc, that's tumor-effective MS, and over here it's radiation necrosis. But when I look at these imaging, it really, all of them I could have called glioblastoma if I wanted to, but as you can tell, 4 of the 5 weren't. So is this a tumor? Is this a glioblastoma? It's a necrotic mass. Here's a FLAIR image. So what do? You do a DWI. Diffusion-weighted images helps you differentiate between an abscess or a necrotic brain tumor. In a necrotic brain tumor, you would not have restricted diffusion. You would have a hypointensity on DWI. This is classic for abscess. You cannot miss that. And that's an abscess. So where do I use magnetic resonance spectroscopy? This is a tool that's underutilized. When a patient comes in with a brain lesion and we can't figure out, I often will look at MRS. MRS, here's the voxel. You see that the highest peak is actually NAA, N-acetyl aspartate, and choline is the red one here. Choline is important. Creatine is important. And this peak here, which you don't see, is for lipids and lactate. So a decrease in NAA is a signal that this could be a neoplasm. It's really a sign of axonal or neuronal loss. Elevated choline is a surrogate marker for increased cell membrane turnover. So choline increases with cellularity. NAA decreases with destructive lesions of the brain. Elevated lactate is usually a sign of a different type of metabolism seen in aggressive brain tumors. Here's an interesting patient who had some subtle left-sided numbness, and you see this hyperintensity here where the arrow is. So we did an MRS. MRS, when it's multivoxel, is also called chemical shift imaging, which you see way over here. So we put this voxel on the other side. That's the green voxel. And we looked at the peak, and the peak was normal. NAA is elevated, choline is over here. But when we get closer to this abnormality here, it turns out that the NAA comes down and the choline increases. This, in fact, was an astrocytoma, biopsy proven. So instead of sitting on this and not doing anything, patient received treatment. Also, MRS is important because here's your obvious glioblastoma, but distance from this, you see the choline very much elevated, the NA is decreased. So this is helpful for radiation oncologists. And I don't know, this doesn't work. So we're going to talk a little bit about diffusion tensor imaging. So diffusion-weighted imaging is really a technology that's user-friendly. This is really done by the technicians. And DTI looks at the tractography. the fibers, because there's some tumors that destroy fibers, and there's some tumors that push fibers aside. For example, meningiomas, metastases don't destroy fibers, they push them aside, while glioblastoma destroys the fibers. So neurosurgeons like to see the DTI prior to surgery. Here you see the corpus callosum fibers. So this is something that is visually very attractive, but very helpful. Here's a patient of ours. We put a DTI superimposed on functional MRI. The purpose of functional MRI is to map out the speech centers, map out the motor centers, and you can see that there's a tumor here, and the tractography, and you can see the tumor right there, and the tracts seem to be surrounding it, but there's a, the left finger tapping tells you that's the primary motor cortex. So we use this relatively often, and we can pick out Broca's. Here's Wernicke's over here, and then the arcuate fasciculus next to this tumor, which is not broken but pushed aside. Perfusion MRI is something else we do. PWI is very important because it tells you the perfusion volume and flow. And in malignant tumors, you have increased cerebral blood flow and volume, while in low-grade tumors, you may not. So here's the difference between a grade 2 astrocytoma, which is up here, non-enhancing, T2 bright, perfusion's kind of cold. And now we're getting into an anaplastic, and you start seeing increased cerebral blood volume and flow. There's different ways to do this, DCE, DSC, and we use also ASL, which is a arterial spin labeling, which means you don't have to give contrast. You just use the blood flow naturally to give a signal for the perfusion study. So here's an ASL on the right. You see that this tumor looks like, it really doesn't enhance, does it? Here's T2. This is a subcortical mass. And when you give ASL, it probably is, it turned out to be anaplastic astrocytoma. It was because looking at the T2 and T1, you would think this is a low-grade astrocytoma, but ASL confirmed that this is a more aggressive tumor. Here's a March 2017, July 2017. Not much difference between T2 flare, contrast. But when you look at the map, you'll notice that DSC, which is another form of perfusion, doesn't show much, but the ASL was more sensitive. So we use ASL. This is a very interesting case. Let me walk you through this person. 31-year-old woman operated a year ago for oligoastrocytoma, located in a very elegant location, the left middle frontal gyrus. She was asymptomatic, but her follow-up MRI showed this. This is new. So this came back, in this MRI, this is a new finding of contrast enhancement. On flare, this is a new finding, okay? So if you're a surgeon and you see this, and I tell them, well, you need to go back to surgery, what would you do? Normally, you would carve that out. You would take this out and then carve a little bit out here. So I said, well, let's not do that. She was a 31-year-old. She was a curator in a museum. And so what happened here is I put a voxel over the lesion that you saw here. See that? I put a voxel over it, and guess what? The NNA is below the choline. So that's hypercellularity. So I knew that was recurrent tumor. What if I put that voxel behind this cavity here? And guess what? The NNA is high, the choline's low. That's normal tissue. So I told the neurosurgeon, let me do a functional MRI. And guess what? In descriptive naming, here's the cavity. It was right below the cavity, but this one is your hand movement. This is your primary motor cortex. It was right behind the cavity. So let me just summarize. We have this new lesion that enhances. It's flare positive. Its MRS shows hypercellularity. Behind it, there's no hypercellularity. It's normal tissue. And the functional MRI showed that the motor is right behind the cavity. So the surgeon knew with this information just went after the lesion. She came out of surgery 6 years ago without any neurological deficits, and she continues to be a curator of a major museum in the United States. So by using functional MRI, by using magnetic resonance spectroscopy, I help the neurosurgeons in how to operate. And this is something every neuroradiologist and neurologist or neuro-oncologist should be aware of. So in respect for Edson Arantes de Nascimento, who just passed away at age 82, success is no accident. It's hard work, perseverance, learning, studying, sacrifice. And most of all, I love what you're doing. The reason I work the hours I do, because I'm passionate in what we're doing, and I do sacrifice for the field of medicine. So I think as also an ex-soccer player, this is apropos, this message here. Now, let me talk about SWI. I came back here. So here's the atrium of the lateral ventricle. You have two black spots here, this one here and this one here. And what is it? Well, SWI could be microhemorrhage or it could be dystrophic calcification. So we can do phase imaging in SWI, where if we switch to phase imaging and it turns to be bright, that's calcification. If it remains dark, it is blood. So this is another way to differentiate. So SWI phase imaging. So this is something we developed. And in fact, neurosurgeons love this. So we have a lot of patients with facial pain syndromes, hemifacial spasm, trigeminal neuralgia, who need microvascular decompression. So we utilize T2 drive, which is a 0.5 millimeters, not 1 millimeter, a half a millimeter thick slices to look at the cranial nerves. And we superimpose that on MRA, which we color in red for angiography. And you can see the vessels adjacent to each other. And then sometimes we even do DTI. So this is called, it's a disease-specific protocol for trigeminal neuralgia or hemifacial spasm or cranial nerve. In this case here, I'm sorry, I should show you. You see this mass over here. So called it, and here's DTI of the trigeminal tract, helping neurosurgeons in micro decompression. We don't use MRI neurography enough. One of the things that neurologists don't do enough is imaging of the musculoskeletal system and the nerves, everything from carpal tunnel, from post-traumatic injury to the nerve roots. We should be doing magnetic resonance neurography much more often. A lecture that I would be happy to give at another time. So right side, this is a patient, right-sided tinnitus and blurry vision with chronic headaches. On the axial field, you can see the crowding at the cervical medullary junction. And in a coronal view, you can see how the tonsils are far beyond this line here. We used a line called the McRae's line. McRae's line connects the Bayesian to the Epistean, which is the bottom of the clivus, the bottom of the occipital bone. We draw a line like this, and then if it's below that, we call that, if it's below 5 millimeters, we call that a Chiari type 1 malformation. And then we do a CSF flow study to see if the Chiari could be symptomatic. So we look at flow behind the cervical medullary junction, and in this case, it's decreased, and then we check for a syrinx. So again, this is a patient with McRae's line, tonsil ectopia, over 5 millimeters. Then we do a CSF flow study at the base of the skull. This is something I've been doing for a while, and I really enjoy looking at whole body MRI. We use a DWI and a stir sequencer. And this case is so astonishingly abnormal. Look at the legs. Those legs are not that's not bone. That's the sciatic nerve, which is about 100 times bigger than what it should be. So this is a neurofibroma. If you look at the red abdomen, that's all plexiform neurofibroma. Everything you see in red here in the legs is a extensive neurofibroma. Again, this is another case that we have not published, and we should, because the imaging is remarkable. Just for note, you can see the intercostal neurofibromas here in red. They'll show up in a moment. You see the neurofibroma. That's all intercostal. So this is NF1. So I use whole body MRI for multiple myeloma, lymphoma, sometimes metastatic disease, neurofibromatosis, pediatric tumors that metastasize, rheumatoid arthritis, and diabetes. In the future, they'll be using whole body MRI for two reasons. One, obesity, to measure the amount of fat, and executive imaging. If you go to places like the Cleveland Clinic, they'll do whole body MRI for you. Imagine, for an executive, if I hire a CEO, like a big shot like Joe Fritz, I want to do a whole body MRI before I hire him to see if everything's copacetic. or normal. So I think whole body imaging will be part, and it's a $280 test that lasts for about 35 minutes. So this is something that I think in the future, in the science of medicine, we'll be ordering more and more. This is something that Dr. Pinter and I have been working on, which is MI protein transfer. This is a new technology. It really reflects concentration on not blood, not flowing blood, but endogenous proteins in brain tumors, which is very interesting because as the tumors get larger, they're what you see here. So this is July 2018. You'll see a T2, a T1 with a little contrast. APT was quite hot. ASL was quite hot. DSC was not. And then in 2018, there was progression. So APT may be a modality to tell us. Here's another case. Postoperative, flare, hyperintense, T1 hypointense with contrast. No enhancement, no enhancement. Was this a recurrent glioblastoma or radiation necrosis? Well, we did another flare study. You see the progression. Here's the contrast study. This is APT. So cerebral blood volume on a DSC was not negative, ASL negative, but APT showed you new onset of proteinaceous material, which is a sign of progressive disease. Black blood imaging. I'm showing you new things that we are dealing. This is really a high resolution vessel wall imaging. It's really something very interesting. So here's a case. You'll see the vessel wall imaging enhancement here. These are vessels that enhance. So vessel wall enhancement, I'm not sure if I have a slide. Vessel wall enhancement or high resolution vessel wall enhancement tells you if the aneurysm wall, if it enhances, is labile, has the potential to rupture. So when you see an aneurysm that's 5 millimeters and you do vessel wall imaging and there is enhancement of the wall, that's the type of patient that they may take to surgery instead of just watching. You see vessel wall imaging in vasculitis. In vasculitis, you see segmental enhancement of the vessel wall, but you also see an advanced atherosclerosis. This is my comprehensive brain tumor. Now I've added APT over here, but this whole study here, T2, T1, fiber tract, perfusion, is about 14, 15 minutes. This is not a 60-minute study. This is relatively fast. This is my headache protocol. That's 12 minutes. My goal is to decrease the imaging of the brain down to 6 minutes. That's a goal that's realistic. In other words, an MRI with high quality sequences, 6 minutes. So this is toward the 5 millimeter. Phillips is working with the Dent to expand and look at spiral instead of Cartesian imaging to improve the quality, decrease the time of the image down to 5-6 minutes. And these are different ways we're doing it and doing research. Again, Dr. Pinter, who's a Hungarian doctor, who's with us for several years now, is involved in this research. So if we do have a 6-minute MRI, that'll revolutionize the meta-economics of neuroimaging. Then you could do 4 to 5 studies an hour. And then maybe an MRI will cost $100. And if it costs $100, then that's going to really going to change the medical economics of imaging. So if you have time, read this article. It's why neuroimaging plays a critical role in shaping the future of neurology. That's Dr. Fritz next to me. And that's an article in Practical Neurology. Please do read that. That goes through some of the issues we've had. It's really an advocacy. I'd like to thank most of the professors that I've worked with who came before me. This is Bill Kinkle, Jacobs, Greenberg, Dr. Bates is still with me and working with me, Dr. Wexler, Dr. Alexandra, Bakshi, Mausdow, Prokop, and this is Dr. Kinkle, who just passed away and was my mentor. Keys to neuroimaging success. Well, this is us teaching here. We have a room here, and often we see Hungarian doctors from all over the world. To be the best you can be. Fellowship, preceptorship courses, teach, educate, start a fellowship, sit on neuroimaging committees, be politically active, be active member of the ASN. So this is the advocacy. Do not accept the status quo. Do not accept the fact that most people feel neurologists should be reading. So I leave you with that. 8:57 on time. And this is and, you know, marketing is important. Here we are marketing imaging as neurologists. So
giving them what they need most, clear information. Dent's Imaging Center has more of what you need most as well. Dent, the largest outpatient neurologic institute in the country. Dent, what matters is what's inside.
So hopefully, as we develop the mind could be a center of excellence in Europe, similar to what we have here in Western Europe. And this concept, this business concept that we have, we are now looking at maybe taking it national and develop centers of excellence around the country. So that's my personal goal as an advocate of neurology and improving the quality of life of our patients. You know, I talk about neurologists, but at the end of the day, when the quality of life for a neurologist, and Agnes will agree with me, when our lives are improved, our patient quality is, and the way we take care of patient improves. So it's a knee-jerk reflex. Improve the quality of life, control imaging, and then the patients will benefit from it. Thank you very much for allowing me to do this. This is taped. I'll be happy to, oh, Agnes said something. If you don't mind, I'll read it, Agnes. This topic is extremely important to all of us practicing neurologists. Can you put up here some of your books, publication chapters? I'll be happy to. I'll have Chris do that. On how are you going to do that, Chris? On the, you know what? Send me your email. I'll be happy to send you some articles that we recently published. I see Jod Garami from Houston with that John Lennon image in the back. That I don't know how you got that one, but good job, Jod. Jod was, you know, we ran a course in Orlando recently at the American Society of Neuroimaging in a parallel practice didactic teaching, and Jod Garami gave a wonderful talk on ultrasonography for neurologists. And also in the audience, we had Monica Ambrush, who's a neuroimaging fellow, talk about sequences. So what's that 6? What's the 6?
There was 6 Hungarian in the faculty of your session. So I think you built.
That was by accident. That was just by accident.
I know. This is why I want to emphasize that what you did, I think, is just a school, but I think you totally forget that ultrasound is also functional imaging. So I think I really would like to see that edit on your slide.
I will correct that immediately.
I wanted to show you, Lennon, because this is, again, nobody is really talking about how much you single-handedly keeping neuroimaging alive in the US and internationally. So this Lennon was painted on the American Society of Neuroimaging conference last year. And in the background, there was a Beatles song, and this was upside down, and I didn't understand what is the submarine and fish doing with neuroimaging. But in the end, the artist swept the image, and then we figured out that's Lennon. So thank you for motivating us. Thank you for keeping us. And I just have one more idea for you, which is, I think, we never seen in neuroimaging books. I think your interpretation and your reading of the MRI scan is nothing what we see in the medical practice these days. So when I saw you doing a MRI interpretation of your patients, not just because you're a neurologist, but again, the detailed, what you see, usually what we read in a hospital MRI reads, sadly, even in Houston, there's no stroke, no abnormality, no space occupying lesion, and done, and says normal. And I'm sure that there's a shitload of stuff get missed, but when I see your report, which is 2-3 page long, and this is where I think your dictation speed is something that I hate. I feel sorry for those people who need to type your reports, but I think that is something that I think you need to teach us more. So I think the interpretation is very important, how you can pass that knowledge to our next generation. And thank you again for continuously teaching us in neuroimaging.
Thank you, Jod, for your comments. And yeah, it's very important us to nurture the next generation, the generation afterwards. I will say, I'm looking at a question that Dr. Virga, neurologist, says that, is there any legal issues with neurologists interpreting? And the answer is, if you're well trained, if you train and either you don't have to even be UCNS certified neuroimager to be able to image. You just have to show some credentials, which either take the examination or do a fellowship. Usually it's 600 MRIs that are read. And then I've been reading MRIs and being reimbursed in that since 1989. So that's not an issue. Neurologists are many of my fellows, Pat Capone, as you know, in Virginia, John Berthelsen in Austin, Texas. I can go down the list. Gobi Satmati in Mississippi, they all reading, they all get reimbursed. So the thing is, are you comfortable reading? And for that, you should either do a preceptorship with us or take the examination, or as Monica in the audience is taking 1 year off and doing a fellowship in neuroimaging. So these are the ways to do it. Dr. Shurkard, I'm sure we'll send you a copy of the talk. Be very happy to, and a few publications that Dr. Shurkard asked for that. So, you know, this is what I gave today is somewhat, you know, interesting cases and here and there, but it's the advocacy and how neurologists should get involved, because it makes you a better physician. If it makes you a better physician, it's good for medicine. When a neurologist interprets an MRI live in a hospital without support, it makes you a better physician. So it's really a survival of our subspecialty. So I'm very happy to still be in the advocacy of it. But I have a great team of people around me, you know, within the Dent and nationally too. So these talks are very important. So as I mentioned, this is actually, the whole lecture will be posted on the Mind website. So that's www.mind.hu for Hungary. So you'll pick it up on that. And previous lectures have also been downloaded. So you can see some wonderful lectures from individuals who are world famous in headache and in other fields of medicine. So please be free to look at those lectures. Anyway, so it's good. It's a Friday. It's 9:05 in the morning. Oh, George, you have a question?
There's one recommendation for everybody. You organized the clinic. Remember that neuroimaging booklet? Yes. It was published in 2009 and I think 2019. That is something that what you as the editor put together so nicely. I think it's worth more than just a regular publication. I think that it was the clinic series and it was neuroimaging.
Yeah.
And it was edited by you. So I think that is something that would recommend for everybody to read.
So I'm going to then send you a copy of the 5 books that I was editor for. The neurology clinics, as you've mentioned, is quite good, excellent individuals. And by coincidence, many of them were Hungarian. I'm not sure how that happens. I think, Zsolt, your name is there as usual. And number 2, Continuum. Continuum is another good one. So I'm going to write all that down. So these are books that I edited, and you can review neuroimaging in stroke, neuroimaging in tumors, headaches, and so on. It's actually quite good. So especially for young doctors who are taking examinations, it's very good to read. All right. So thank you very much. We'll get back to work. I know Agnes has to work. And thank you for my friends in Puerto Rico. Julio, ¿cómo está? That's about all I can say. But it's always a pleasure. And we'll meet again in 4 weeks with another lecture. Thank you very much. Tom,
thanks, Laszlo.
nice to see you, Tom.
Thanks a lot.
Bye.
Bye. See ya.
Bye-bye. Goodbye.